Okay, we're going to start today's session. Hello, my name is Deborah Cohen, and I am the physician volunteer moderator for the MAVEN Project. And thank you all for joining us today and our friends at Mariposa Community Health Center for hosting today's session, which is Seeing Red, Vascular Anomalies. I'd like to tell you a little bit about Dr. Boiko. As a pediatrician in the Air Force, she became interested in the rashes, moles, and birthmarks she observed in her patients. After completing a dermatology residency, she joined the faculty as a pediatric dermatologist at the University of Cincinnati, then spent most of her career as a general dermatologist at Kaiser Permanente in San Diego, where she also served as a voluntary professor of pediatric dermatology at UC San Diego. Upon retiring, she joined UCSD as a clinical associate professor of pediatrics and dermatology. She is an active volunteer both in the US and abroad. She is a community outreach volunteer with the Vista Community Clinic, works with the San Diego Medical Society, and also Farm Worker Justice. She has given over 200 educational lectures, volunteers for the American Academy of Dermatology, and has received numerous awards. And with that, Dr. Boiko, please begin.
I am so excited to talk to you in Arizona because my daughter went to the other college in Arizona, whose name I won't mention, but she was in marching band, and the marching bands of Arizona State and U of A were really good friends. And we love visiting your town. So thank you very much for this invitation. I don't know why my slides are not advancing. There we go. Okay. So I don't have any disclosures. At the end of this talk, you should be able to differentiate hemangiomas from what people call stork bites and port wine stains, and recognize which hemangiomas can pose a danger to life and limb, and also have a plan to get specialist help urgently. So think of these things as we're talking. And I think everyone can agree that if you saw this baby for the first time in your practice, you would say, gosh, that left eyelid looks really impinged, and I wonder if that baby can even see much out of it. Let's get them to a specialist right away. I'm dedicating this talk to one of my professors in medical school over 40 years ago, who was a child neurologist. And one thing that I really remember from his lecture to us was how important it was to undress a child. Sometimes we're in a hurry, or we're already behind, and we feel like we could just make the diagnosis from looking at one thing. But if you have a complicated patient, or even if you're not sure of what might be going on, just the few extra minutes it takes to undress the child and do a complete skin evaluation may give you the diagnosis. As a medical student at New York University visiting, I heard the other medical students and residents using WNL, which they said stood for We Never Looked instead of Within Normal Limits. So today's lecture will talk about how important it is that we need to look. So the important take-home messages today are undress the patient and have the family bring all meds to every appointment, and not only just have the meds there, but actually look at what is in the medications. So to suggest to you, once again, look and look again, especially at the label underneath the stuck-on prescription label. I'm showing you a picture of this Taro product that says hydrocortisone cream, 2.5%. And I'm also showing you, like, bizarrely, nitroglycerin ointment. Why am I showing you that? Well, back in the day when hydrocortisone 1% cream was a prescription, I had a child come in and the parents said, well, doctor, every time we put this medicine on for his eczema, his skin turns redder and he screams. And the paste on label with the child's name on it said 1% hydrocortisone, but the label was actually stuck on a tube of nitroglycerin. That's why it's very important to always carefully look at the medicine. Sometimes they're from other countries and they have ingredients you don't expect. Also, remember Peter Parker from Spider-Man. He had a spidey sense, and you all have a spidey sense. So, like, you know that when you have this feeling something isn't right, or I'm not comfortable with this, or I'm not sure about this, use your spidey sense. Use that electrical impulse to your brain where you instinctively respond before you're consciously aware of danger. If you see something and you're not comfortable, lean into that feeling and get help. So this is a patient I saw when I was a general dermatologist at Kaiser. He had a hemangioma on the back of his hand, and he was treated with radiation. And here it is 70 years later, and he has something, I thought it was a malignancy, but it was actually a precancerous spot. But still, it shows you like what we do to an infant may have consequences we may not even be around to know about. So, of course, we want to try to do the best for every child, but we also want to consider the long-term consequences. So why do I show you this picture? First of all, you can see that something is very wrong here. Something, some red vascular blob blocking the ear and impinging on the eye. But where do these hemangiomas come from? Why did this child get this hemangioma? So there's all these theories about maybe there's some kind of hypoxic stress in utero. Maybe the placenta is sending stem cells to the skin, or these cells are making new vessels. But one thing that's very important to know is regardless of why hemangiomas actually come up, they are your normal blood vessels. So parents are always terrified that this is cancer. So one thing that I can always say to them right off the bat is, this is not cancer. And you can hear the sigh of relief as you tell them that. So this is how you remember, or how I have children and families remember the names of hemangioma. So think that heme means blood and angioma means benign vessels. And remember these characters, some of you may remember them from your childhood. He-Man, who's on the left, and She-Ra on the right, they were the cartoon characters. So it's a He-Man gioma. It is the commonest neonatal significant vascular malformation. We'll be talking about what's an insignificant malformation in a second. It's rarely visible at birth. Usually, if you go back and even look at pictures the parents have taken, you may see a pale area, the skin may look completely normal. But if you do see a red mark there at birth, you would code it as a congenital hemangioma, which means that it was present at birth. Usually these arise in the first 2 to 6 weeks of life. And here's the difference. This is the quote unquote insignificant. Of course, it's very significant to parents, but as they kind of troll the internet for these photos, they'll see these nevus simplex, salmon patch. Sometimes they're called stork bites. When I was an intern in 1978 in the Bronx, I told the parents, don't worry, it's a stork bite. And because English was their third language, they said, you mean a bird came into the nursery and bit our child? So, it's a cute name, but I think using salmon patch, because the color of salmon has nothing to do with eating salmon, is a better name, or nevus simplex would be the code word. So here's the difference between a nevus simplex and a port wine stain. And sometimes you may have difficulty distinguishing them. And the patients actually would come to me as a pediatric dermatologist. A port wine stain is called port wine because in Portugal, there's a kind of wine that's this dark red color. So it's the wine from Portugal. So port wine stain is actually a capillary vascular malformation. It's present right at birth. All babies, when they come out, they're red, and when some of the redness subsides, you can see this. And I think you wouldn't have any trouble referring these children to a dermatologist. But sometimes these hemangiomas, as they come up, they can also sort of look like a port wine stain, or maybe something else that you're not familiar with. So if we're trying to fit something into a category of hemangioma, it's something that is evolving by growing over time. So we can classify these hemangiomas by their location, whether or not they're present at birth, how many. You can see this baby has at least 3, and this baby actually had 21 when you looked everywhere. what they're made of, what kind of blood vessels, and even now their genetic sequences. So I thought this was very interesting. This was actually from UCSD Rady Children's. And this baby had this kind of looks like a squashed raspberry on the abdomen. And if you just look at it, it's hard to pick out that it has a pink or a reddish color because the skin is brown. But when you use a dermatoscope, which is the special magnifier that dermatologists use, it looks like kind of a bag of worms, and those are blood vessels. So this was just a small hemangioma. So at that first visit, you always want to observe the baby. And of course, when you walk into a room, I know that you're already, you don't even realize it, but you're using your spidey sense in there. You walk in, you're like smelling. Does people smell clean? Was the parent drinking coffee? Does the child look lively and alert? Are they well groomed? Are they clean? Is there a good interaction between the parent and the child? And so you're observing, you're taking your history, and then you're doing your physical exam. So here are some risk factors for hemangioma that you may notice before you even walk in the room. The baby has low birth weight. So many of you have seen preemies with hemangiomas, and these micro preemies, these babies that stay in the nursery for 8 weeks or longer, many times we will get called in our consult service for babies where they now are 3 or 4 pounds, and suddenly a hemangioma is coming up 8 to 10 weeks even after birth, and it seems like it's out of the ballpark of the 2 to 6 weeks. Babies that are female, white non-Hispanic twins, triplets, and advanced maternal age, which is 35 or over. So this is a patient I saw who I'll call Renee, and she was a normal term birth. And at the age of 2 weeks, her pediatrician referred her for this weird lip rash. And she was fine. Okay, so when we do our exam, we see that she feels she's responding appropriately. She's drinking out of a bottle. She's otherwise not having any difficulty breathing. So those are all the key things. Whenever you see something around the mouth, think of the entire airway. So always fully undress the child. You can imagine that if I had left the diaper on or I just peeked under the diaper, I never would have seen this hemangioma. So obviously, when you're undressing the child, you're assessing tachycardia. Does the child look like they're straining to breathe? If you see a hemangioma, especially a large one or around the airway, make sure you get a blood pressure and a heart rate, and look for respiratory distress. I think all of you are familiar with babies retracting, babies flaring their nostrils, trying to get that breath. Look over their entire body for additional red birthmarks, any kind of midline pit, anything unusual, and take a picture of these. And then, of course, feel the liver edge, because if you feel more than an edge of a liver, if you feel an enlarged liver, there could be hemangioma within the liver. So after you are taking your history, you're still looking while you're talking, you're again observing the baby for wheezing, retracting, as we talked about, rapid heartbeat. Do they have any difficulty feeding in your history? Do they have poor weight gain? So think about for a moment now that you're in the room with a child. It's a 2-week-old, regardless of any hemangiomas, any other physical appearance. What do you do if you see respiratory distress or cardiac failure? So now today, when you go back to your exam rooms, just take a look around and take a look at your office setup and think about, if you saw a child in respiratory distress, where would the nearest oxygen be? Where would the telephone to call, or maybe you have a phone in your pocket. How could you call for help? And then the next thing is, when you see a child with respiratory distress or cardiac failure, do you feel confident in making a diagnosis? And if you do, what would your diagnosis be? And then, do you feel confident in initiating that evaluation and treatment? So think of all these things ahead of time, and then you'll be prepared when that patient does come to your office. So this was a cute little uh, way to remember the signs of a possible heart defect, but this could also be any child in distress that's not oxygenating. So color, oxygen, the heart rate, the breathing, sweating, and trouble feeding. So one thing that's very important to say is, I don't know. I don't know is better than making a wild guess and going down the wrong path. So some strategies when you're not sure of what you're seeing, is it a hemangioma? Is it a port wine stain? Is it a nevus flammeus, or the old name for port wine stain? Or is it a nevus simplex, which is just I won't say stork bite, I want to. So text a photo to a trusted colleague, say, what is this? You can Google it, but I think send a consult to MAVEN is one of the best things you can do. You can write a referral if the child otherwise seems stable, but know that the average wait time might be 3 months or even longer for pediatric dermatology, or you could call a pediatric dermatologist, there's plenty in Tucson or Phoenix, to expedite an appointment. If you're really worried about a patient, the best way to get them a sooner appointment is to talk to the staff in the office and say, look, I'm really worried about this kid. Is there any way you could possibly squeeze them in? So here is Renee when she's 2 weeks old, and she has that little whitish patch. And if you kind of think about it, the upper lip looks kind of thin, and that lower lip already looks kind of a little bumpy. And then if you really look hard at the right cheek, do you see a few little red spots there? So here she is now at 4 weeks old, and look at the size of that lip. That's what I would call a fat lip. And look at how red dots are coming up all over the area on the lateral cheek. And now we're starting to worry about what else is going on. So here she was at 4 weeks old, and she's surprisingly still very doing well, able to eat, no respiratory distress. But a red flag to refer urgently would be a child that looks like her. I don't think that any of you want to manage this child in your office. If it's big, you know the length of your thumb is 2 inches, especially on the face, sometimes on the arm or upper trunk. If there's shortness of breath, if the baby is not feeding, if it's blocking a vital structure like an eye, an ear, airway, and you see these babies with these hemangiomas in the diaper area that are ulcerating. It's not likely that they're going to bleed out from that, but it's going to be extraordinarily painful every time the child urinates, and a nidus for infection. So some of you have heard of this syndrome called FACE, P-H-A-C-E. Sometimes people call it FACES, but I talked to the people that actually wrote the article, and they said it's FACE, not FACES. But no matter what name you use for it, it is either a segmental, and a segment is just a part of your body, like your head or your arm or your leg. So it's either segmental, or it's more than a 5 centimeter, your size of your thumb, hemangioma on the face or scalp. Could be also on the neck, arm, or there's some additional criteria. So this is a nice little drawing that tells you that if you see this on the FACE, you could have posterior fossa problem, along with the hemangiomas, arterial and cardiac anomalies, eye anomalies, and even chest anomalies. So it's a clinical diagnosis. Then once you have this child, you could see, well, gosh, the hemangioma doesn't look like a big deal. It just looks like a little red patch on the chest and face. But look at this baby. This baby's obviously in respiratory distress, has a nasal cannula. The mouth is open. And so if you see something that has this extent of it, you want to evaluate the respiratory tract. So here are these. Here's again, what FACE syndrome stands for, like we saw in the pictures. My slides are not advancing. Let me try. There we go. So there's even a support group for people with face. And you can see in these pictures that the children can have anything from a slightly distorted lower lip as an older child to a child who looks almost like in the right bottom picture, like they have a port wine stain. So you have access to vascular lesion clinics. These are multidisciplinary specialty clinics with a lot of different people on the team, like respiratory people and genetic people and hematology people. And these are usually located at a university or children's hospital. And I put the information about the Phoenix Children's Hospital in case you should have a serious case that can't be accommodated in Tucson. So this is Yesenia. She was a newborn and she was a normal delivery, except that she had meconium aspiration. So they're monitoring her in the NICU. And I want you to take a very good look at her hands, because really everything looks normal in this picture except that the baby's being monitored. Now, this is at 2 months. And you could imagine when the mother saw this come up, she thought, well, maybe when the baby was in the hospital, she was burned, because it almost looks like a burn, but it doesn't have those really sharp edges like a burn might have. It looks more like a splash or a splatter. And this was a red vascular thin plaque that came up slowly over the first, after 6 weeks of life. Sorry, it came up between 2 and 4 weeks of age. And she was otherwise well. I should be in my own slide. So here was this baby, and this is a limb or segmental hemangioma. And one interesting thing about these is, do you see how in some of the skin folds, it's kind of swollen up like a balloon that has a rubber band around it? And so sometimes there can be a little breakdown in those areas. So we monitor those carefully. But if I put that right hand up to the left hand like this, the right hand would, the skin would only be enlarged, but the joints and fingers would match. So this was her when I saw her when she was 3 years old. You could see the tremendous fading of the spot. There's still redness there. And then again, do you see how it almost looks like a little scarring in the creases where it had gotten inflamed in the past and the skin broke down a little in the creases? So this is a red flag, a limb hemangioma. You can see in this picture, this baby looks ill, and that right lower limb is grossly enlarged and ulcerated. So of course, if you had a child like this, they would probably be airlifted to a medical center and cared for there. So if you see that there is a red patch or plaque, a thicker area of vessels on the leg or arm, if it's bigger or smaller than the opposite limb, if the child's, obviously this child could not use that leg at all. If you feel the limb, another thing that we forget about talking about is not only looking, but touching. So if you ever feel these spots, if you feel it pulsating or it feels hotter, then there's probably arteries involved. And so that's also a reason for immediate referral. And then if the skin is breaking down, if it's ulcerated, if it's painful, that also needs an immediate referral. And then on the eye, so if you see this child's eyelid on the left, it looks like you could still see half of the pupil. But if you see that half of the pupil is already covered by the enlarged eyelid, then you're decreasing that visual field, and that may be a permanent effect unless you can get that eyelid less puffy. So you're not only referring them to pediatric ophthalmology and pediatric dermatology, but you're aware that the visual field is being blocked. Another red flag is the nasal tip. If you've ever heard of Cyrano de Bergerac, the famous character with the big long nose, it's called a Cyrano defect. And when you see one that's right on the bulb of the nose, it's affecting the nasal cartilage. So the way the nose develops over time will be affected. So what is the early intervention? Sometimes not only giving a medicine that we'll talk about later, but a skilled plastic surgeon can go underneath the nasal cartilage, shell out that hemangioma, and then you're done with the problem because it's physically removed. So that needs early intervention. And then even though this just looks like one small little spot, if you also observe, and again, remember that even if you see just one little spot on the lip, it could mean that there are additional hemangiomas in the airway that are blocking it. So if you see distortion of the lip, always look for an unrecognized airway hemangioma. How do you know that? Because they're having trouble breathing, they're having trouble feeding, they're not gaining weight. So all those things are reasons to be looking for an airway hemangioma. And then even if it's just the kind of thing like when I was a child growing up, I would see children like this, and the doctors would say there's nothing you could do for it, and they had the big red mark, and we didn't really know what it was. But when you have these larger hemangiomas that ulcerate, it can leave permanent scarring. So even though these are not impinging on any airway, they're not impinging on the visual area. Who cares if there's a bald spot if they have a lot of hair on their head and they could just comb over it? We care, and we want to give them the best possible outcome. So just to prevent scarring is another good reason to refer. So again, you can see here, there's a hemangioma on the chest. It's regressing or involuting. You can see the white and kind of tan areas of scarring and some erosions. And this is a different child, but this is how it ends up. It looks like a saggy bag. So whatever we can do to head off that unfortunate appearance, we want to do. So again, if you have more than 4 hemangiomas, you want to check out the liver on ultrasound. Statistically, if you have these little kind of cherry dots and you have more than 4 of them, then it's possible that there could be a hemangioma in the liver that could lead to heart failure. And so do you see how in the left-hand side, I'm holding, or the mother's holding up the neck? Because if you don't carefully look at all these creases, you're going to miss one. And look at this one that's right on the perianal area. So this is the child where you saw the other hemangiomas, and we counted 21 hemangiomas on this child. So again, remember, if there's more than 4, the liver may have more. So in this case, if you count up all these little dots and there's more than 4, please get a liver ultrasound. So here's the multiple cutaneous infantile hemangiomas. The old name we don't use anymore is neonatal hemangiomatosis, but again, look everywhere. And again, more than 4, liver ultrasound for sure. Doesn't quite rhyme. Another red flag is, again, this child who has the acronym of pelvis or sacral, P for perineal, E for external genital malformations. I did see a child that had this and was born with no urethral opening to the outside of the skin. So that child was already in intensive care and had multiple surgeries before I even saw them. Lipomyelomeningocele. So again, very carefully check that crease and make sure that you're examining the motor function of the legs. The vesico-renal abnormalities, like I told you, imperforate anus. Of course, you're not going to be seeing that child if they have an imperforate anus. They're going to be in the hospital for a while. And then something that looks like a skin tag, that's not just a skin tag that you would snip off or freeze. That's a skin tag that you would refer because it's a little flag on the surface. It's like the flag sticking up on the golf course to show you where the hole is that you put the ball in. So another thing that you may see sometimes is you will see this butterfly marks, are very appropriate for the Mariposa health, which is a capillary stain. Plus, if you see something that looks fatty, like a lipoma, any hair tufts, any curve in the buttocks crease. Many of us see buttocks asymmetry when we're looking at the buttocks crease. If the one leg seems different than the other. If one leg is not moving the same way, then a neurosurgeon, obviously, you're going to consult. But I usually do an MRI if I see a raised area, a sunken area, or an abnormally hairy area. So there are other kinds of hemangiomas besides the kind that are kind of like the ocean tide. The water rushes in. That's when it gets bigger, it gets redder, and then the water rushes out. That's when it ulcerates and finally goes away, maybe around the age of 4 or 5, or maybe lingers. But there's a different kind of hemangioma with different kinds of blood vessel receptors in it called rich, which is a rapidly involuting congenital, again, born with the hemangioma. So you see them at birth and they seem to just kind of quickly go away, like within 4 to 8 weeks, they're already going away. So if you're not sure, best to refer. This is on the midline of the back of on the occipital area of the skull. So go ahead, and if you're not sure about this, go ahead and refer that child. And again, you're looking to make sure that they're moving their arms and legs normally and breathing okay. So this was a baby that I saw. This was the daughter of one of our physicians. And it's hard to see, but this baby actually had a surgery at birth, a day after birth, because they had a large vascular lump there, and the ultrasound was equivocal, and they were wondering, is it a tumor? But it was actually a hemangioma, and they got a frozen section, and so they debulked most of it. But what was left, it looked like a Shar-Pei puppy. So those uh, hemangiomas growing before birth can actually act like tissue expanders. And when I saw this child when she was 3 or 4 years old at a picnic, her neck looked completely normal. You couldn't even see the old scar because as she grew like a Shar-Pei puppy, she absorbed the wrinkles. So another kind of hemangioma is called a niche, which is a non-involuting, again, congenital hemangioma. And all you see are these capillaries, dilated capillaries, telangiectasias, very commonly seen on the jaw. This was very similar to one of my patients that had this. And usually when we see them, we watch them. And if they don't spontaneously start to involute, then we will use the laser. Lasers, like if you have these kind of blood vessels on your face, lasers are great at getting rid of these without leaving scars. This will not respond to propranolol. See, I'm giving it away that I'm going to talk about propranolol. So rich and niche are both, if you put the Doppler instrument over them, they're very high flow. They don't express this tissue marker for hemangiomas called GLUT1 because they're different genes. And again, there's no urgency to it, but as long as everything else is going well, they can have that pediatric dermatology referral. Another concern that I briefly talked about earlier was the ulcerated hemangiomas. So you're seeing a child for the first time, maybe they're recent immigrants or they haven't had access to healthcare before, and they have this hemangioma, it's ulcerated. So the first thing you want to do is protect it. If you have a lot of money, you could put Tegaderm over these. That helps a lot in helping it to resolve. If you can use an ointment, if you notice that it looks infected, you may want to use something like bepirosin ointment. Obviously, if it's bleeding, you're going to stop the bleeding. You may use a little compression bandage again. You can use that to stop the bleeding gauze, and then over it you can put the Tegaderm, and you can change the Tegaderm every few days. But you're really, you may need to use some acetaminophen, but you want to make an urgent referral to dermatology. Oftentimes, some of these children will start on propranolol, even though it's already involuting to help it involute faster. But as it involutes faster, it may ulcerate more. And the other thing that we can do is laser to kind of cauterize or seal off the bleeding area so it's not bleeding so much. But you really don't want to try to manage this yourself. And then just to tell you, don't ever feel pressured into using a treatment just because you can read about it in a journal. If you feel that you don't have enough knowledge or confidence to use a treatment, please don't start it. But if you do feel confident, if you have learned about it, if you've had some mentoring about it, if somebody else is nearby, just in case you're having a problem, then it's fine to use these treatments. So one of the first hemangioma treatment options you may turn to is a topical beta blocker called timolol. And this is used in the eye. So if I am writing a prescription for it, I always write in capital letters in the computer that this is meant to be used in the eye for hemangioma, because otherwise parents get I'm sorry, it's meant to be used on the surface of the hemangioma, not on the eye, because otherwise parents will have the pharmacist just tell them, oh yeah, you put the drops in the eye, and the parents somehow think, well, if I put the drops in the eye, it'll help that ulcerated hemangioma on the buttock. No, it goes on the actual site of the hemangioma. And then that its cousin, propranolol, which is an oral medicine to help hemangiomas. Now, how do these work? They work really well if you are treating an actual hemangioma. The generic form is actually off-label use. The brand name, which is called Hemangiol, is an FDA-approved use, but the dosing is different, so you have to make sure that the parents understand exactly what dose to use, because the propranolol that's generic is a different concentration than the propranolol that is a brand name. And we use these sometimes in rare cases, like they're having respiratory distress. They may be hospitalized and used in combination with steroids to try to shrink the hemangioma quickly. You'll see the hemangiomas get better in 2 days. The way that they discovered this was that in France, they had a lot of children in the hospital with the face syndrome, or they had an eye or an ear or airway trouble. And the children, because at that time they only had steroids, they were all getting Cushingoid and their blood pressure was going up. So somebody said, oh, let's give the, like we have a long tradition of use of propranolol for pediatric cardiac problems. So we'll just give them the, for their blood pressure, we'll give them the propranolol. They came back the next day after a dose of propranolol, and they like, the hemangiomas are shrinking. What's happening? This is amazing. So we still don't exactly understand why it happens, but it works great. But remember again that the generic propranolol oral solution itself comes in 2 different combinations. And so you have to be sure, because some children have had propranolol overdose because they get the 40 milligrams per 5 ml and they say like 1 teaspoon. Well, you can imagine that's like a double dose if you give the wrong thing. And then Hemangiol, again, the brand name, I'm mentioning this because this particular brand name is FDA approved. They do have a program to get this to children in need at no charge on their website, but this is a completely different dose. You can see 4.28 milligrams per ml is very different than the generic of 20 milligrams per 5 ml, which is different. So the bad news about propranolol is that occasionally there have been children. I have not seen children with these problems, but we always check for this. Make sure the parents know that if the child's lethargic, unresponsive, the blood pressure's low, they're, obviously if they're, we don't check a blood sugar, but these are possibilities, especially the death due to overdose. So that's why it's very important to not only read the labels, but to make sure that the parent can show you what they're using to drop the medicine and how much they're taking up. One thing that was very hopeful when I was doing my dermatology training was when the Candela laser came out in the late 80s. Everybody thought, oh, well, just laser everything and it'll be like magic. But unfortunately, even if you can catch these hemangiomas early, it doesn't prevent the deeper growth, because the laser can only penetrate millimeters below the surface and there are vessels below it. So we use it as a temporary fix for ulcerated hemangioma, and it is at the discretion of the experienced pediatric dermatologist, and you will often have to fight with insurance to cover it. then how about just like cutting the thing out and getting rid of it? So there are cases where the surgery will be helpful, like the nose. We like to do the surgery before age 3 so the children don't remember what their face looked like or they don't remember the procedure. If it's inevitable, if there's like a huge ulceration or it's like bleeding so much you can't stop the bleeding, you're going to have to remove it. Or it's ulceration, or it's obstructing a vital structure. And sometimes they'll start earlier and do a little at a time. So to remember what we've just talked about, I really like this table. So remember that if you see something in these high risk areas, for example, you look in the armpit, again, we're looking everywhere, and you see ulceration, that is a high risk feature. The beard area, if you just take your hand and stroke the area where a beard might be growing, even if you're female, that area is also very prone to obstructive airway hemangiomas. Female breasts, there could be developmental anomalies, so you want to make sure that you address that early. Of course, in the diaper area, ulceration, the ears, eyes, lips, and then remember its location. It's the larger hemangiomas at any location more than 5 centimeters, or if there are 5 or more, you could have liver hemangiomas. And I think all of you would recognize, even if you couldn't call it severe congestive heart failure, a baby that is struggling to breathe and its lips are blue, you are going to get immediate help. So what I'd like you to try today is when you leave this session, if you haven't already done so, try to establish a liaison with a dermatologist with pediatric expertise. And certainly you could do that through MAVEN or a vascular lesion group to add to your resource list before the next challenging patient arises. So once again, don't forget to undress the patient. Look literally in every nook and cranny, have good lighting, have the family bring all the medicines to every appointment. This will also help you know if they're using the medicines, because if they come back with an unopened bottle, they haven't used it. And make sure you carefully look at the labels and make sure that medicine is what it's supposed to be. Now, I want to share this wonderful resource with you. This is on the Society for Pediatric Dermatology website. And this is information, it's both in English and Spanish, about what a hemangioma is. This is a summary of what I've talked about today. And then if you aren't already aware of this website that is called DermNet, it's dermnetnz.org. All of you should have this like in your phone or on your desktop, because if there's any question you have about any dermatology condition, it is on this website with wonderful images. And it's like a free dermatology textbook. So, and if you're giving a talk yourself, you can take slides from here. And then finally, the journal Pediatrics has clinical practice guidelines for the management of infantile hemangiomas. And all these people are world experts on hemangiomas. And I want you to know that it's not just dermatologists. If you look under the word free and you look under Alona Frieden, you'll see Cynthia Baker. And Cynthia Baker is a pediatrician. And Cynthia Baker can take care of hemangiomas just as well as I can. So if you want to develop your knowledge, you can. And you could be like my colleague, Cindy Baker. So thank you very much for your attention. I'm very happy to answer any questions that you have.
Thank you so much, Dr. Boiko. That was really complete. I particularly like that you gave a phone number for reference for the Mariposa area. And I also really liked your anecdote about the stork bite, because it reminds us about how important language is when we're explaining things to patients. So I really appreciated your talk a lot. So we do have time for questions. Does anybody have a question to pose, either by raising your hand or by placing it in the Q&A? looks like you gave such a thorough presentation that there are no additional questions. The dermatologists at MAVEN Project are among our most busy specialists, our very busiest specialists. So I know that they handle many, many inquiries every day, and they're always available to you, as are all of our MAVEN Project volunteers. Anybody have any questions at all before we end this session? We're a few minutes early.
So I have a question for the folks at Mariposa. Do you have a designated pediatric dermatologist that can help you urgently with questions about hemangiomas or other questions? So I see, no, we do not. So I think that this is the time to develop that relationship. I'm not sure how you personally might do it, but you might, as an organization, ask your CEO or somebody to reach out to a person and say, like, if we have an urgent or emergent problem, are you willing to see this patient? Or are you willing to see a patient? And you may find that there are some colleagues who will see an occasional patient who is uninsured or underinsured. They don't want to be like the person that you suddenly are sending a flood of people to because they won't be able to handle them. But it might be nice to have that resource. And remember that you always have MAVEN. We will try to answer even an urgent consult within 24 hours to at least get you guidance on what to do right away. But I think you also know how to stabilize somebody until they can be transported for emergency care, right?
We do have a couple questions. One of them is, should any patient with a lesion that could be an ash leaf lesion be referred to a neurologist?
I think it would be fine to send that even to a dermatologist first, because sometimes the ash leaves can, I know you're thinking about tuberous sclerosis, but sometimes something that looks like an ash leaf could actually be something different. So a dermatologist would be happy to look at that. And then I see, how can we send a pic to you guys HIPAA related? So I also see that I have had, I think it's no experience with MAVEN, but once you request a picture, we are told we cannot send it. Can you contact MAVEN? There's a person that works on these problems about how to get the pictures through. So there should be somebody on the MAVEN website, or if you want to send me your contact information, I would be happy to, if you want to just send it as a private message, like your email, I'd be happy to put people in touch with you from MAVEN so that you can send these pictures, because as a pediatric dermatologist on MAVEN, the picture is so incredibly helpful. And no matter how beautiful your description is, without the picture, it's very hard for me to give you good advice. So why don't, if I see it's Edith, it looks like Edith Hernandez. Okay, I see it. Great. Thank you. Let me write this down. And I will be in touch with this person, and we'll figure out how to get you on MAVEN.
Any other questions? Well, we've got such a helpful expert right here with us today. Okay, anything else that you'd like to say, Dr. Boiko?
I want to thank you for listening to me, because I know how hard it is. You guys, I know exactly what kind of work you're doing. I was in the Air Force doing general pediatrics. and you have a lot of people to see. The patients have a lot of barriers and challenges, and the work you're doing is so important. I want to be able to support you any way that I can. So even if you're having trouble getting a child in to see a specialist, I can follow that patient with you until they can get that appointment. So we at MAVEN are here to help you and educate you. I have a second lecture that talks more about port wine stains and other blood vessel anomalies. So if you'd like to hear this part 2, just let MAVEN know, and I'll be glad to make that lecture for you.
And just for anyone who's not from our anchor clinic at Mariposa, we are available to give educational sessions to any clinic that would like it. And we have a variety of topics that we can help with. And we also do mentoring services to community providers at any stage of their career. So please look into that if you're interested in having a clinical mentor or even just somebody to talk to about the processes in your clinic, just for help with patient flow, anything like that. And again, you can request educational sessions by being an anchor clinic yourself. Okay, I think with that, we're going to stop recording and we will be done with this lecture. Thank you. Thank you for joining.